This presentation is a topic review of Pes Cavus, and the information contained herein is from numerous journals and texts, and will provide a general overview of Pes Cavus. I'm going to touch mostly upon the etiology, biomechanics, physical exam, and radiographic exam, and less on treatment. A subsequent lecture and presentation focused solely on treatment is forthcoming. Pes Cavus describes a condition of the foot in which a high arch does not flatten with weight bearing. It's a complex deformity with various components, and the deformity can be related to changes in the hindfoot, the forefoot, or both. There's various mechanisms that can lead to the muscle imbalances that produce the cavus deformity. And because the underlying cause of this muscle balance and deformity can vary, each case should be analyzed individually with specific attention to the anatomic structure of the bones, the strength, weakness, or spasticity of the muscle tendon units, and any soft tissue contractures. It varies fairly widely in the literature, but 80% of the time there's identifiable causes with regards to the Pes Cavus deformity, wherein 20% of the time there is no identifiable cause. Etiology of Pes Cavus can vary, but the most common etiology is a hereditary motor sensor neuropathy, of which Charcot-Marie tooth is a member of, if you will. There are two types of Charcot-Marie tooth. Type 1 is an autosomal dominant inheritance pattern with the onset typically within the first 2 decades of life. It causes severely compromised motor nerve conduction, and its incidence progresses from 20% in the first decade to 70% in the second decade. So these patients are affected severely and early. Type 2 Charcot-Marie tooth does not have any clear inheritance pattern, and its onset is typically later than type 1. Additionally, it usually affects the lower extremities in isolation, usually bilaterally, and patients have much less sensory loss. And this is the type of CMT that I think we see more often in our office. And in fact, these patients may ultimately be diagnosed after their first or second visit with a foot and ankle specialist because of perceived deformity within the feet that is progressing over time. The third type of hereditary motor sensory neuropathy that can result in a cavus foot deformity is Diagnostic syndrome, which is quite rare and has a recessive inheritance pattern. Specific to Diagnostic is severe sensory loss, kyphoscoliosis, limb ataxia, nystagmus, and myotic pupils. The onset is typically in infancy, and this is thankfully the sole form or type that can actually decrease life expectancy. So that's hereditary motor sensory neuropathy. Other causes of a Pes Cavus deformity are poliomyelitis, spinocerebellar degeneration, and Friedreich's ataxia. Post-traumatic disorders can sometimes produce a Pes Cavus foot, particularly compartment syndrome, where there's a contracture of the intrinsics, the plantar fascia, and resultant clawing of the toes. Additionally, there's a loss of normal agonist-antagonist relationships, producing effects similar to those that would be produced by a neurologic lesion. Lastly, a direct traumatic nerve injury could also take out a compartment and lead to agonist-antagonist abnormalities. In 1984, in Clinics of Orthopedics, Sabir and Little proposed a pattern of progression of muscle atrophy producing the cavus deformity that started first with the intrinsics, followed by the anterior compartment, the peroneals, and finally the posterior compartment and calf muscles. They postulated that the posterior compartment muscle atrophy followed a predictable pattern based on the axonal length, with muscles with longest axons affected first. So overall, their pattern of weakness started with the intrinsics and continued on as depicted here, with the final group being the anterior compartment and specifically the tibialis anterior. However, later in subsequent review of their patients and of the patients presented by another study by Roger Mann that we'll review, failed to demonstrate any patient with normal function of the anterior tibial musculature. Four years later, in the patient population described by Roger Mann, the posterior tibial and long flexors were noted to be normal. The function of the tibialis anterior was typically fair or poor, with the peroneal brevis tendon or muscle being very poor, with the longest being normal. Mann also described the relationship of muscles to the various joint axes of the foot and ankle, and described the muscles posterior to the ankle as plantar flexors, anterior to the ankle as dorsiflexors, medial to the subtalar joint as inverters, and those lateral as everters. Strength, he also postulated, was determined by size, but also distance from the axis of a joint, and therefore, for example, the gastrocsoleus is a strong plantar flexor and inverter, whereas conversely, the tibialis anterior is almost pure dorsiflexor, but has some weak inversion power. With this data, Mann proposed a theory about the cause of the cavus foot deformity in patients with CMT, but underscored the importance of understanding the agonist-antagonist relationship with regards to the muscles of the lower extremity. And when one muscle or muscle group is weak, its antagonist group will gain a mechanical advantage, and therefore weakness of the tibant permits unopposed medial and plantar flexory pull of the peroneus longus. The loss of the peroneus brevis permits the posterior tibialis to adduct and invert the foot. And the deformity progresses as the plantar fascia and the intrinsics contract over time. The toes become clawed as the intrinsics can no longer hold the metatarsophalangeal joints in a neutral position, and this ultimately pulls the fat pad distally. The toe extensors dorsiflex the metatarsophalangeal joint, which is accentuated by the long toe flexors. The weakness of the muscle combined with deformity ultimately causes instability at the ankle. Remember, the hind foot is in varus and prototypically the forefoot is in valgus. And so at heel strike, the hind foot being in varus, as the foot progresses to flat foot, plantar flexion of the first ray causes further supination of the forefoot because there is no normality with regards to the peroneus brevis to resist this force, and this produces significant instability at the ankle joint. In the stance phase, the heel remains in a varus position, causing rigidity at the transverse tarsal and CC joints. And this loss of hindfoot motion decreases the ability to dissipate force at heel strike, This, combined with decreased weight-bearing surface of the foot, produces increased pressure in the calcaneus and heel and along the lateral border of the foot, which is a common complaint of patients who have a cavus foot deformity. So we'll move on to the symptoms of Pes Cavus, and these can vary widely depending on the cause and the degree of deformity. A common complaint, however, with that said, is generalized fatigue of the foot, and this is thought to be caused by rigidity and stiffness in the subtalar and transverse tarsal joints, which minimizes the foot's ability to disperse weight and ground reactive forces, leading to an overall sense of foot fatigue. Patients can also have pain under the heel, particularly laterally. Patients often, as pictured on the left here, because they're overloading their lateral heel, may develop compensatory changes with a tremendous amount of hypertrophic callus-like tissue on the lateral border of their heel. As the hindfoot varus increases or progresses over time, of course, it could cause instability or lateral ankle instability issues and issues with the peroneal tendons. I myself personally over the years have had at least a couple handfuls of patients who presented to have their swollen lateral ankle examined and ultimately at some point were diagnosed with Charcot-Marie tooth. Patients can have rapid irregular lateral wearing of their shoe gear. They often have problems with their toes due to clawing of the toes and corns developing over the apexes of these deformities from overlying shoe irritation. So how do these patients present and what do they look like when they present? It's important to identify the etiology of these patients whenever possible. So it's important to ask about neuromuscular disorders in parents, siblings, or grandparents because Charcot-Marie tooth has a variable penetrance. It can be a bit confusing. That said, any new onset of unilateral deformity should be considered evidence of a spinal cord lesion until proven otherwise, and therefore it is recommended that a thorough neuroevaluation, including imaging of the spine and spinal cord, be undertaken. So most of these patients will be recommended to a neurologist for a more in-depth consultation, but in the office we can do our own neurological exam consisting of deep tendon reflexes, sensory exam including vibration, position, light touch, sharp dull, etc. Also important to take note of the range of motion at the ankle, subtalar joint, transverse tarsal joints, the metatarsophalangeal joints in a seated position, and of course have them stand and observe any changes upon weight bearing, and trying to get a feel for whether the deformities are fixed and rigid or they're supple and flexible and reducible. So with the patient standing, you want to degree the amount of hindfoot varus that they have, and then when they're seated, try and get a feel for the amount of compensatory forefoot valgus. And you do this the same way you would looking for compensatory forefoot varus in somebody who has hindfoot valgus, which is you bring the heel and subtalar joint into neutral and then apply a ground reactive force to the forefoot. And you're looking for plantar flexion of the first ray, potentially, but in more significant cases, plantar flexion of the adjacent rays as well. Equally important is assessing the contracture of the plantar fascial ligament. I think that this is underutilized and under-recognized. I think that, at least myself, I have this kind of contrarian opinion or thought of plantar fasciotomy or cutting the plantar fascial ligament, but that is, of course, when we are talking about it in concert with a patient who has recalcitrant plantar fasciosis. A plantar fascial release or plantar fasciotomy can be an imperative step in eliminating these patients' deformity. And at least for me, it's hard to not think negatively about a plantar fasciotomy because of the aforementioned. In the seated position, you want to individually test each compartment and muscle with careful attention paid to the agonist-antagonist imbalances, which ultimately cause the deformity within the Pes Cavus foot. This is absolutely paramount when it comes to surgical decision making. Coleman block testing can be very helpful in the office if it's utilized the correct way. This simply assesses the flexibility of the deformity, and it involves placing the heel and the lateral midfoot on a 1 to 2 inch lift, such as a textbook or a wooden block. If the heel remains in varus, it portends a rigid deformity, and the heel varus likely will require something local to the heel or intrinsic to the heel. Conversely, if the heel reduces to neutral, it tends to suggest a more flexible deformity. Often I hear the terms forefoot driven, hindfoot driven. The results of this test do not decisively determine whether the corrective reconstructive surgery is intrinsic to and contained wholly within the forefoot or the hindfoot, but rather, again, it just tends to suggest whether the deformity is flexible or rigid. I think most patients that we do these reconstructions on need procedures throughout the entirety of the foot, the hindfoot, the midfoot, the forefoot, and so this should not be understood as a test to determine where the patient's surgery needs to be centered. With patients standing, you can, again, not to be redundant, assess the degree of hindfoot varus, as you can see here on the upper left. When looking from behind, when you look at these patients from the front, you will see the prototypical peekaboo heel sign, which is wherein you see much more of the medial heel than you would in a neutral foot. And of course, you can appreciate the profoundly high arch here. So we'll move on to the radiographic assessment of these patients, and this, of course, like most things, starts with standard weight-bearing foot and ankle films. Typically, a calcaneal pitch angle greater than 30 is indicative of Pes Cavus with severe heel varus. On the lateral, you will see loss of parallelism of the metatarsals, and on the AP view, you will notice that the talar bisection is lateral to the first metatarsal, whereas conversely, in working up a patient who perhaps has a progressive collapsing foot deformity, you will see that bisection fall medial to the first metatarsal. Strong consideration should be given to obtaining EMG and nerve conduction tests. After all, these patients have deformities in their foot due to imbalances with regards to muscles and tendons, and these imbalances are usually due to weak or absent impulses for those muscles to fire. So the EMG and nerve conduction velocity test can help determine where exactly these deficiencies are. Treatment. The goal of treatment is to allow the patient to ambulate with greater stability and comfort. And after the cause of the deformity is known, the diagnosis and treatment options should be discussed. And there should be an understanding as to whether the deformity is static or likely progressive. A patient may be able to live with the discomfort and deformity that they have today, but if they know it's likely to be 20 to 40% worse in the coming 5 to 10 years, that certainly might change their mind as to what they want to do. Generally speaking, when treating Pes Cavus operatively, we're talking about two treatment arms, one being osteotomies and soft tissue balancing, and the other being arthrodesis procedures for more rigid deformities. In patients who are not candidates for surgery or who do not wish to undergo surgery, there are non-operative measures that can help optimize these patients, primarily physiotherapy, accommodative shoe gear, a molded total contact inlay, possibly in a flexible case, a lateral heel flare. Patients with severe motor loss can benefit quite a bit from bracing and an AFO. When there is less motor loss present, an articulated AFO can be employed. When it comes to surgery, the decision-making process is and should be complex. Each one of these patients is slightly different from the next, and so there's no one procedure fits all approach. Each patient should receive a careful assessment of all the components of their deformity, and you have to take into consideration or keep in mind the underlying cause to determine and help determine for the patient what is best for them. Primarily, this revolves around determining whether or not this deformity is going to be progressive or is likely to be static in nature. Most patients that we see have slowly progressing deformities. Let's talk briefly about the individual procedures that are most commonly done in conjunction with other procedures to reduce or eliminate the deformity consistent with Pes Cavus. The first one is a plantar fascial release or a Steinler stripping. This can play an extremely important role in reconstruction because contracture to the plantar fascial ligament contributes to forefoot plantar flexion and hindfoot varus. But just like a TAL or gastric recession in a progressing collapsing foot deformity, reconstruction is rarely done in isolation. So is, or such is the case with regards to a plantar fascial release in the patient with a Pes Cavus. It almost always requires other additional ancillary procedures. When it's performed, it involves direct sectioning of the entire width of the plantar fascia through a medial longitudinal incision just superior to the distal calcaneal fat pad. This can also be done just distal plantarly on the plantar surface of the foot, just distal to the calcaneal fat pad medially. This tends to be a safer approach from a neurovascular standpoint. It is not recommended, however, to do a percutaneous or EPF because visualization of the long plantar ligament is impossible. A posterior compartment lengthening, either in the way of a TAL or a gastric recession, should be considered in these patients, and not so much because of an existent equinus contracture, which truly limits ankle range of motion, but just as the Achilles can be a deforming force in a valgus hindfoot, so can it be in a varus hindfoot. So in a case where there is going to be some work done on the calcaneus, either a subtalar joint arthrodesis or perhaps a lateral slide or Dwyer, if there's tightness and contracture in the Achilles, it's going to make manipulating the os calcis more difficult than it needs to be. As I stated initially, the specific treatments for Pes Cavus are going to be included in a subsequent presentation, but we will quickly touch on some of the more salient procedures in each region of the foot, starting with the forefoot. The Jones procedure is a common procedure done for a cocked up hallux. The EHL is released from the distal phalanx and transferred to the neck of the first metatarsal through a bone tunnel, prototypically. It's done in conjunction with a fusion of the interphalangeal joint, and it removes the EHL as a deforming force and uses it to assist in correcting plantar flexion of the forefoot. The Girdlestone Taylor or FDL transfer is common to the lesser digits. It converts the FDL from a deforming force causing clawing of the toes to a corrective force assisting in plantar flexion of the proximal phalanx. It's typically done in conjunction with an arthroplasty or an arthrodesis. It starts with identification of the FDL in the flexion crease at the base of the proximal phalanx from the flexor digitorum brevis by the raphe. It's sectioned in the distal incision at the distal phalanx and transferred dorsally to the proximal phalanx through division or with a biotenodesis screw. The arthroplasty is then fixed with a K-wire, which is prototypically placed transarticularly so that the toe can be held in some degree of plantar flexion. Moving to the midfoot, one of the most common procedures done is a dorsiflexory first metatarsal osteotomy, which helps correct the fixed forefoot plantar flexion. It's usually combined with a plantar fascial release, and by a long shot, typically the first metatarsal in isolation is osteotomized, but occasionally the second and the third may be incorporated as well. It's recommended to assess the plantar fascial release and the extent of the release and the entirety of the release before osteotomizing the second and third metatarsals. The proximal cut is perpendicular to the foot, and the distal cut is converging and perpendicular to the axis of the first metatarsal. This is done about 1 to 2 centimeters distal to the first TMTJ. Other midfoot procedures include the Cole closing wedge osteotomy, the Jappus V osteotomy, and the truncated wedge arthrodesis described by Joss. I list these more for historical purposes. I have not myself performed any of these procedures and only seen them done a few times at most. So we'll quickly move on to the hindfoot, where you would locally address a hindfoot varus. And this can be done with a dwyer-calcaneal osteotomy with or without lateral translation, or a calcaneal scarf osteotomy or Malerba-like osteotomy of the calcaneus. These are some pictures illustrating the incisional approach and the orientation of the osteotomies for a Dwyer out of Mark Myerson's second textbook. If the hindfoot deformity is rigid and or arthritic, one may be best suited to perform a isolated subtalar joint arthrodesis or a double or triple arthrodesis. So I breezed quickly over the aforementioned procedures because I wanted to talk a little more in depth about soft tissue balancing, and with that goes a discussion of tendon transfers. Generally, the requirements for a tendon transfer is the tendon to be transferred should have similar strength, at least 4 out of 4, to the tendon you're transferring it for. The tendon should be inserted close to the tendon to be replaced and routed without angulation. as of course this will affect its torque and pull. There of course should be flexibility in the joints involved. When you're transferring a tendon, you're transferring it to impart a certain action on the joints that it affects, and of course if the joint is rigid, there's no place for a tendon transfer. Fixation of the tendon should be to the bone or indirectly using another tendon, and agonists are preferable to antagonists. I'm not going to go over this word for word. That's why I placed it in the lecture. This is out of Foot and Ankle Clinics. This is a general algorithm regarding tendon transfers and soft tissue balancing by Ortiz and Wagner. You can look this up. The most common tendon transfer performed in Pes Cavus reconstruction certainly is the peroneus longus to peroneus brevis. It is performed when the peroneus longus is preserved, but there's a weak peroneus brevis, and transferring the longus to the brevis restores eversion of the hindfoot and stabilizes the foot and gait. Additionally, it should be noted that this can be done fairly quick and fairly easily through the same incision as a calcaneal osteotomy or subtalar joint arthrodesis incision. Tendon transfer of the posterior tibialis to the cuneiforms is another fairly common tendon transfer. It's done when or because the peroneus longus to peroneus brevis transfer was enough to stabilize the hindfoot, but not necessarily the midfoot. And so it acts to eliminate the primary deforming force of the hindfoot and reinforces and strengthens the tibialis anterior. This is typically done through the interosseous membrane and fixated to the cuneiform with an interference screw and an adjacent anchor, so that there's 2 points of fixation. One note is, or one tip is, you want to try and place the posterior tibial tendon underneath the extensor retinaculum to prevent postoperative bowstringing. Going underneath the retinaculum also can slightly shorten the traveling distance of the transfer, and sometimes just a few millimeters can make the fixation into the cuneiform much more easy. So one might perform the posterior tibial transfer in isolation to the cuneiform. However, it can be used in conjunction with a concomitant transfer of the tibialis anterior and peroneus longus. And this would be utilized in patients who have severe peroneal muscle loss. Again, it's the same as the previous isolated PT transfer with the addition of the peroneus longus and the tibialis anterior. The posterior tibial tendon is transferred to the cuneiform, as previously noted, through this time the tibialis anterior. Then the peroneus longus is transferred and tenodiced into the tibialis anterior. And this achieves inversion-eversion control, much like a bridle on the horse, thus the name bridle procedure. Another well-described tendon transfer is the splat or the tibialis anterior transfer. And this is usually done after the hindfoot is corrected, but there's persistent residual midfoot supination. It's done when the previously mentioned transfers have already been done and the tibialis anterior has at least 3 out of 5 strength. A much more in-depth presentation with regards to surgical reconstruction of the Pes Cavus deformity is forthcoming, but for now, a quick review of what we went over in the way of a quick quiz, which is something I'd like to do with my residents. Which of the following are true? CMT is a type 3 HMSN. CMT usually involves severe sensory loss. CMT typically causes muscle tremors in the hands, CMT type 1 has a cavus deformity that usually presents 70% by the second decade of life. So the answer is D. CMT is a type 1 or type 2. Deheron Sadas is the type 3. CMT usually involves severe sensory loss. The key word is usually. The type 2 CMT causes severe sensory loss, but it's not the more common form. Type 1 is the more common form. Same for answer C. The correct answer is D. On a lateral x-ray of the cavus foot, you will commonly see calcaneal pitch between 20 and 30, posterior displaced symaline, plantar flexion of at least 2 metatarsals, or arthritis within the midfoot before the hindfoot. The correct answer here is B. Typically, the calcaneal pitch angle is in excess of 30 degrees, and typically there's plantar flexion of the first metatarsal and first metatarsal in isolation. It's less common to see metatarsals 2 and 3 plantar flexed as well. And of course, patients may have arthritis within the midfoot and the hindfoot with Pes Cavus, but they certainly don't have to. And there is no literature suggesting that it happens sequentially with the midfoot first and the hindfoot thereafter. According to the literature we just covered, the muscle that retains the most strength is, this is an easy one, it's the posterior tibialis. The most common tendon transfer used in cavus reconstruction surgery is the bridle procedure, the peroneus longus to brevis tendon transfer, the splat or the tibialis anterior to the cuneiforms, or the FDL to the peroneus brevis. Of course, the answer is B, peroneus longus to peroneus brevis. It's very effective and usually, if not always, can be done through the same incision as your hindfoot work. To add additional correction to a Dwyer, the posterior fragment can be, choose all that apply, plantar flexed, dorsiflexed, translated medially, laterally. The answer is B and D. Dorsiflexed and transferred laterally. Just in the same way, when you're correcting a pes plano valgus deformity, the posterior fragment can be translated in a plantar flexed and medial direction to correct the deformity. In a known cavus foot with progressive etiology, a Jones procedure should be included, a plantar fascial release should be avoided, arthrodesis procedure may be favored, or a miscompartment syndrome should be suspected. The correct answer is C. The bridle procedure, A, recruits the peroneus brevis to aid in stabilizing the hindfoot. B, requires a subtalar joint fusion to protect the transfer. C, seeks to balance dorsiflexion and plantar flexion balance of the midfoot. Or D, restores inversion-eversion balance to the midfoot and hindfoot. The correct answer is D. The most important information regarding surgical decision-making stems from EMG, NCV, plain films, Coleman block testing, individual muscle testing. The answer, of course, is D, and this may be the most important principle of this presentation to remember. In a flexible cavus foot, when one holds the hindfoot in neutral, A, in a flexible cavus foot, the heel cannot neutralize. B, the forefoot will fall into valgus. C, the forefoot will fall into varus. Or D, the toe contractures will diminish. The correct answer is B. Just the opposite, as if one holds the subtalar joint or the hindfoot in neutral in someone who has a progressive collapsing foot deformity, The forefoot will typically fall into varus. The most important agonist-antagonist relationships to assess are between, the answer is B and C, and I think if you can keep these two relationships in your mind when working up a patient, I think that it makes things much more focused and easy to understand. And that again is the agonist-antagonist relationship between the tibant and the peroneus longus and the peroneus brevis and the posterior tibialis. That's the end of this presentation. Thanks for listening, and keep an eye out for part 2 coming soon.